Welcome back to the P3 podcast. As always, I'm your host, Alicia Reeve, and today we're going to be revisiting a topic that I've spoken about time and time again on multiple different P3 platforms, but I thought off the back of a couple of conversations I've had really recently with a few clinicians, and a general theme was coming about. So I thought I would put it together into a podcast episode for you. So we're revisiting how you can improve your knowledge, skills, and confidence when it comes to exercise prescription, especially if you're a clinician working in general podiatric practice. So let's get into it. The Progressive Podiatry Project, here to share knowledge, insights, and information for you to improve your clinical practice and, most importantly, help you help your clients. Now, understandably, when you're working in general podiatry practice, when you see a patient's name pop up in the appointment book, and whether or not it's from the patient saying it when they've booked in or what they've typed in when they've booked in online, you see that it's a musculoskeletal pathology that's coming through the door. And I know for a number of clinicians that in itself sends the anxiety through the roof. Now, hopefully what we're going to do today is give you a couple of practical tips and strategies on how you can leverage your general podiatry practice. So, one, you can improve your knowledge, skills, and confidence when it comes to writing and prescribing exercise therapies, but also adding value to your existing patients. And then also is reducing that anxiety when you see a musculoskeletal pathology walk through the door. So first up, I think it's probably a good place to start is, why do I think that having a general podiatry practice sets us up for improving our knowledge, skills, and confidence immensely when it comes to exercise prescription? So if we stop and think about all of the elements that make up a really robust, well thought out, and hopefully successful exercise and rehabilitation program, yes, there are a few elements. One, having an understanding of tissue physiology and function, then having an understanding of pathophysiology and functional deficits that may present, having an understanding of how tissues respond to load. They're some of the key elements, but then the other elements are us needing to have an understanding of the patient or the person that we're dealing with. And then another thing is we need to be working towards a goal. And in order for us to work towards a goal with our musculoskeletal patients, we need to be following up with them. So having review appointments. Now, one thing I do know that clinicians struggle with is, how often should I be reviewing my rehab clients? Now, if we take that element of stress out of the equation, because we've got our general podiatry patients that we may already be seeing in a 6, 8, 10 or 12 week rotation for their general skin care, for their general nail care. If we're already seeing a patient at that frequent of an interval and they don't have an active musculoskeletal pathology like plantar fasciopathy or Achilles tendinopathy, then that in itself removes one of those elements of stress, because you will already have your review appointment booked in. Now, with what we're going to be talking about today, this isn't in any way, shape or form delving into the area of over-servicing, because I do have an issue with that. I don't think clinicians over-service as much as they think they do. I think we under-service significantly more than over-servicing. However, when we've got someone that is coming into the podiatry clinic, they're here for general nails or general skincare, whatever it is, then we're often having those conversations with them, right? Just, how's your day? How's the family? Blah, 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 blah. If you find that you have a patient that they may mention something. So, it's winter, my feet or my joints are feeling a lot stiffer when I first wake up in the morning, or it's a little bit achy when I first get going. Explore that a little bit deeper. Now, I do have another podcast episode on this, and this is the one that's called Ask Better Questions, Get Better Results. But essentially, if a patient mentions something like that, just dig deeper. Don't just brush it off like, oh yeah, it's winter, everyone's joints get achy and cold. Okay, well, how often are you experiencing that? Is it impacting anything? Is it concerning you? Because gathering that information, it sets the stage and for you to be able to possibly intervene, not unnecessarily, but you may be setting yourself up for helping them more than what you originally thought that you could or would be doing if we were sticking to just the general nails, general skin. And your patient may not have even been aware that it's something that you could help them with. So, all right, the patient has mentioned that I've got this little grumble or something that's been bothering me, but not enough that I would seek out specific care for this problem. So they've mentioned that, and let's just say that it is a little bit of stiffness or achiness in the feet when they first get up. It's an older client. After we hit the age of 30, we're all on the road for having some arthritic changes occurring. It's natural. It's the bonus of having birthdays. But with that, it does come with a subset of symptoms that is often stiffness at times. And we do know when it comes to osteoarthritis that movement is one of the best symptomatic relievers for a number of reasons. And part of it even is just movement is stimulating that fluid flow into and out of tissues, which is great for inflammation, for pain, for tissue integrity. So if our patient has said, okay, well, I'm experiencing this, and then you go, oh, well, there's actually a couple of really simple exercises that I might be able to give you that might help with those symptoms. Would you be comfortable or happy for us to do that when we finish up what we're doing here? And if they say no, that's fine. Just be aware to next time that you see a patient, if they mention something like that, again, dig deeper, go through. You will find that there are some patients that will go, yes, that would be fantastic. Now, again, remember, you're not over-servicing here. You're just adding value to an existing appointment. Now, there are so many exercises. They don't have to be complex. You don't have to be standing on Swiss balls and doing squats and all of this circus garbage. Even just some really, really basic foot mobility and strengthening exercises. So toe waves, toe scrunches, toe extensions, the short foot exercise. They're all very, very simple exercises that people can integrate very easily into their daily lives, because if someone is sitting down, they're having lunch, it might be, okay, well, for 30 seconds before you get up out of the chair, do this exercise, and you might do that 2 or 3 times a day. So that is one thing when it comes to exercise prescription is, I think the key for especially people when it's not a short-term pathology that we're dealing with, where it's more a long-term symptom manager, or there's a long-term behavioral change that we're seeking to help them, it's the better we can integrate any exercise intervention into what their daily life currently looks like, the higher the chance is that they will adhere to that for the long term. The more disruptive it is, the less likely it will be adhered to long term. But if you have someone who's a gym junkie and then you just write them a very, very well fleshed out rehab program, they're already going to the gym. They may be performing these exercises in the gym. So that's not disruptive. If you've got someone who they've got 1 hour a day that is their spare time and they like to go for a walk, or they go swimming, or they play bowls, or whatever it is, but then you've introduced this 1 hour gym program that they need to do, they're going to have to sacrifice something that exists in their daily life, take that out of the equation and replace it with this, less likely to be adhered to long term. Anyway, so with this, now it comes to the dosage, and this is one part that really, really trips clinicians up, and that is what's the perfect dose? Now, remember, we're not dealing with life or death, and the human body is an amazing piece of equipment. It is, as long as we put our body somewhere in the general realm of where it should be as far as movement stimulus goes, the body will often respond positively and take care of the rest. So this is where, if we think of our physiological loading is almost like a bell curve. At one end, we've got overloading. At the other end, we've got underloading. And in the middle, we've got the happy place, physiologically loading. Now, it's not 6 sets and you're physiologically loading, 7 sets and you're overloading. It's the cumulative load absorbing fluctuations day by day. So if we have someone who we give them 3 sets of 10 repetitions, that may significantly overdose one person. If we give someone else 3 sets of 10 repetitions, it may significantly underdose them. Then for someone else, 3 by 10 might actually be within their physiological loading limit. Now, if you are not confident with sets and reps and the prescribed dosage, another way that you can approach this is AMRAP for time. AMRAP, as many reps as possible for time. So this is one that I use very, very often for this type of patient that I'm talking about, where it's not a long-term specific adaptation that we're after, where we need to be really prescriptive with what we're prescribing as far as exercises go, because we're after a specific tissue adaptation for a specific task. If it's just introducing a little bit of movement, that motion is lotion, then it may be AMRAP for time that is more than suitable. And so let's say we're doing the toe wave exercise. So toe wave, I usually get people feet flat on the ground, all toes extend up together, starting from the hallux, fold the toes down. Now, I always explain to patients that because of anatomy, the toes won't move individually, but getting a little bit of a wave. So first toe, second toe, then waving through to the fifth toe. Now, I'll tell them, okay, what you're aiming to do is as many repetitions as you can, slow controlled movements for 30 seconds. Now, if you go really fast, that's fine, but for you, the best thing is to go slow and controlled. So in that 30 seconds, you may only get 5 or 6 repetitions out, and that's fine. Even that little bit of movement, if we do that 2 to 3 times a day, that can have some really positive impacts on that joint stiffness that you may be feeling. Now, when people start intrinsic foot exercises or just general foot exercises, cramps often plague. So what I'll usually tell patients is if you get a cramp, that's fine. The clock is still ticking. So we start the stopwatch, you've got 30 seconds. You might get 2 repetitions out, then you might get a little bit of a cramp. Clock is still ticking. Just shake it out. And then once your foot feels like it's relaxed and good to go again, you might have another 7 seconds left on the clock. Just try and do another repetition. So in that 30 seconds, you may have done 3 repetitions. That's 3 more than what you had done 30 seconds ago, and your body is likely going to like that. So don't stress about trying to get a huge amount of repetitions out in that time. It's just the fact that you are doing that little bit of movement that will likely see some results. Now, I find that this is super, super effective at getting patients that they're not really a big fan of prescriptive exercise, even though this is a scripted exercise, but it's not 3 sets of 10 repetitions that we're going over the top with technique. You can literally be sitting on the toilet, you can be watching TV, you can be reading a book, whatever it is. When you go to get up out of the chair or off the toilet, you can just do these exercises and then off you go. And when we're dealing with exercise prescription, typically what we see is the lower load an exercise, so these exercises are quite lower load, what we tend to see is the lower the load, the more frequent we can do this. So there isn't any harm in getting someone or advising them that they can do this 2 times a day, 3 times a day, 5 times a day, because if we put it all together cumulatively, it might be 2.5 minutes, and totally it might be, say, 12 repetitions. So not a huge amount of tissue loading that we're doing, but just having that frequency of movement, short dose, high frequency, that can, especially if we've got stiff joints as a result of arthritis and birthdays, that can symptomatically help quite a lot. And then basically when you review them in 6 or 8 weeks, when they're coming in for their general nail appointment again, follow up with them. How are you finding the exercises? Then they can give you some feedback. And then this is where the next skill set development comes for you, because they may say, oh, I was doing the exercises, they felt really good. Are there any more ones I can do? That opens up a window of opportunity for you to progress the exercises. Are you going to change the exercises? Are you going to add load? Are you going to get them to do it a little bit more? So it opens up an avenue for progression. But then it also opens up an avenue for regression. Oh, I was doing this exercise, I kept getting cramps, I couldn't do it, but I want to do this. Okay. Start thinking, well, what is a regression from that type of exercise? Is it moving to an isometric? Is it a shorter range of movement? Is it a shorter duration of time? So reducing some of those dosage variables that you've set out. Now, again, because you're not going for sets and repetitions, it's just as many reps for time, we've taken out 2 of the dosage elements that often stress clinicians quite a lot, sets and reps. So with this, the remaining dosage variables are frequency, time, number of repetitions, or the tempo, and range of movement. So it's a few of those elements that we may look at there. And then the last skill set development that I feel is probably one of the most important is when people haven't been doing the exercises, exploring that and exploring why they haven't. Did they keep forgetting? Were they finding no benefit for it? Whatever it is, it allows you to have those conversations because they're often the most, not difficult as far as combative or anything like that. It's just difficult when you have someone who hasn't been adhering because triggering those levels of intrinsic motivation, troubleshooting why the prescribed program hasn't fit into their daily life. Has there been a motivation factor? Has there been mitigating life circumstance? It's just exploring that because they're the patients that we'll often see not have great rehab outcomes because if you're not doing the rehab exercises, then you're not getting the tissue stimulus, therefore you're not going to get the response. So having an explore of that. Some patients, and this one's quite common, is I just kept forgetting. Okay, well, set a reminder in your phone. So what time do you usually get up and you're brushing your teeth? So it might be if they set their morning alarm clock, then set a reminder for that before get out of bed, do foot exercises. So I do that with quite a few patients. There will be sometimes that they'll let me set 3 reminders in their phone if I want them to do the exercises 3 times a day. So it's basically, and you can set the repeat reminders. So basically it just keeps annoying them until they actually do it. And some people, they'll get irritated by that and just turn it off and they won't do it. That's okay. More issues for us to troubleshoot later on when we review. However, it may just be those simple strategies of introducing a reminder or workarounds to how you can get them to do those exercises throughout their day-to-day. Now, these are skills that are arguably the most important because the best exercise is the one that gets done. Like I said earlier, if a patient's not doing the exercise, they're not going to get the response from the exercise, which means they're not going to get the rehab outcomes that we're after. Now, just pausing for 2 seconds there, if you do want a free rehab resource, now it doesn't matter if you're a general podiatrist, a musculoskeletal podiatrist, it will help if you are looking to create any form of prescriptive exercise program for your patient. So it's called the Movement Prescription Blueprint, completely free resource. You can download this at progressivepodiatryproject.com/blueprint, and it just guides you through the exercise prescription thought process. So a few prompts in there to help you gather the information that you need from your patient to write our really clinically reasoned and well thought out individualized exercise programs. So again, free resource, head there, download. Now, what we've covered today is a few of the dosage variables that we can explore. So we've done AMRAP and AMRAP for time. So as many reps as possible for time. And then if we want to explore, or if you want to explore a few more of the dosage variables a little bit more in depth, we do have an existing podcast episode that I did with Jackson a few months ago, which is using VAS and RPE in rehab. So VASP, visual analog scale of pain, and RPE, rate of perceived exertion. So there's some ways that, again, we're not heading into specific scripted sets and repetitions. It's a bit more of a pathway for how we can eventually get to that. Because one thing to consider is when we're doing general exercise advice and general exercise prescription, often our prescriptions are exactly that. They're generalized. So like I mentioned earlier, as long as we're providing stimulus that puts the body in the general realm for positive adaptation to occur, good things will happen. Now, when we're heading more into performance, so it might be general exercise advice or it might be early stage musculoskeletal rehab. Either way, with both of these cohorts, the prescription or the dosage can be quite general. We might be using AMRAP for time for our older arthritic clients or someone who's just really adverse to wanting to introduce movement into their life. But then if we're dealing with a relatively reactive musculoskeletal pathology, we may be using the visual analog scale of pain combined maybe at times with AMRAP, but then also coupled with RPE as far as exercise intensity goes, not the Berg scale of intensity. But then moving on from there, as we've gone from, say, general prescription, and early stage rehab, then oftentimes, especially if we're looking for more performance goals, that's when we head into our more scripted sets, repetitions, rest breaks, frequency, all of that. So it is a little bit of a pathway, and there's no sort of flick on, flick off switch. So you don't go from rehab mode to performance mode. It's a transition. So when I say performance mode, that's transitioning into strength and conditioning. But anyway, that's a little bit more than what I wanted to discuss today. I'm not going to go down those rabbit holes because we do have a few episodes that exist on that. Today, I just wanted to focus on a couple of actionable strategies that clinicians in general podiatry practice can utilize to begin improving their knowledge, skills, and confidence when it comes to prescribing exercises. So again, general podiatry practice, the perks, you've got patients that you're already seeing on a regular schedule, and you're simply adding value to their consultation. So it might create a touch more paperwork for you, but oftentimes when we've got most of our general clients, there tends to be a few minutes buffer. And also it's a learning experience for you. So utilizing that time to give them more bang for buck, give you more experience and confidence, so then you can help more of your musculoskeletal clients when they come through the door. So we've got our regular schedule. Then you're also learning movement cues. How do I explain different movements or similar movements to different people? Because what you will find is everyone's level of movement literacy is so wildly different. So what makes sense to one person to get them to perform the movement how theoretically they should be doing it will be different from person to person. There may be some people you need to try 4 or 5 different ways to explain something before they understand it. And that's great practice. That's one thing that makes you a really good prescriber of exercises, or just in general, being able to communicate information to multiple patients, because everyone, again, has different ways that they understand things. So it helps with our prescription as far as movement cues and dosage, and then also the following up. So following up as far as the questions that we're asking, troubleshooting when things are going wrong, if they're not engaging in their rehab or their exercises that you're prescribing, and then getting us thinking about, okay, they're enjoying this, how may I progress this? So again, a short episode as far as my usual ones go, but hopefully this has given you a good starting point to delve into exercise prescription a little bit more with a little bit more confidence. And as always, would love to hear your thoughts. So if you're listening to this on any of the platforms where you can leave a comment, Spotify, LinkedIn, YouTube, just leave a comment. Would love to have a conversation. If not, you can email me, p3podiatry@gmail.com. That's it for today. It's been great. I'll catch you next time. Cheers.